Welcome to the Psychoanalytic Therapy lecture. I've broken this into several different sections, which we'll talk about as we get started. So I thought this was funny. I like Parks and Recreation. So a psychoanalytic lens, it's the idea that an author's unconscious desires and anxieties can actually be found in whatever they've written, be that a book or a report or something like that, a blog. Lots of people like to blog or vlog these days. So ultimately, any type of literature, from poetry to prose, whatever it is, acts as a manifestation of an author's internal desires and thoughts. So, cool little tip there. I thought that was interesting. Freud is the developer and the theorist behind psychoanalytic theory or therapy. And this theory is strongly shaped by his past events, his upbringing, his childhood. He was a part of a very large family, as your textbook talks about. And his approach to this theory is that it's very deterministic in nature, which basically means that we are driven by irrational forces, by internal unconscious motivations or desires, things that we're not aware of, that we don't foresee, or that we're not sure maybe what's going on. He believed that we were driven by psychological, biological, instinctual forces, and that a huge part of his approach is uncovering whatever those unconscious desires were, which we'll get into here. So the unconscious, it stores all experiences, memories, repressed material. So have you ever done something and wondered, why did I just do that? Or why did I say that? Or wow, I sound like an idiot right now. If you have, then Freud would say, well, that's the unconscious needs or motivations, and they're coming out somehow. They're showing themselves. So the cure or the goal of therapy is to identify the meaning of that behavior, identify what's going on, uncover it, and basically bring the unconscious into the conscious where we're aware of it. We're aware of whatever those desires and drives and motivations are. So basically identifying, why do we do what we do? What's the meaning behind our behavior? Let's become conscious of those things. So the id is the untamed drives or impulses. It's that illogical side, the amoral side. It's definitely driven by a desire to satisfy instinctual needs. You can think of it as the toddler at the grocery store, that if they don't get what they want, they're going to throw a tantrum, they're going to be screaming, and they're going to be very loud. Basically, we want to experience whatever that pleasure factor is. Another example of this would be impulsive buying. If we're impulsively buying things online or spending, just doing whatever we can to get whatever that thing is that we want. And this is driven by the pleasure principle, which is the idea that we're driven to satisfy whatever that instinctual need is. And that basically we want what we want, and we're going to do what we can to get it. So another way that this is portrayed is in the video with Kronk, where he has two angels on his shoulder, and the bad angel would be considered the id.
Listen to that guy. He's trying to lead you down the path of righteousness. I'm going to lead you down the path that rocks.
So the id doesn't think about consequences or the repercussions of our actions.
Shoulder angel.
Don't listen to that guy.
Then we've got ego. So the ego is the executive that governs or controls and regulates our personality, our behaviors. So it basically tries to help bring the id under control so that the impulsive action isn't happening as much. The textbook uses the example of a traffic cop. I like to think of Boss Baby, because Boss Baby's very on top of it and in control and driving the bus and making things happen. The ego is more strategic and creates a plan to achieve goals. The ego relies on logic rather than going into things blindly or following the id's impulses blindly. And then lastly, we've got the superego. So the superego can be considered that parental figure. It's the side of the ego, the id, these three. This is the version, or the side that's more punitive, more demanding. It strives for perfection and represents more traditional values and the ideals of society. So it also tries to inhibit the id while trying to also persuade the ego to focus more on moralistic goals rather than realistic ones. We've got defense mechanisms, which are really interesting. So there's a couple different things to focus on and discuss here. One is that defense mechanisms can be beneficial and can be helpful in terms of coping with whatever's life has going on, like anxieties, stressors, and it can help prevent the ego from becoming overwhelmed. So normal behaviors that are adaptive in value, those are what can be helpful in terms of defense mechanisms. When this becomes an issue is when it is overused or used to the extent where we're no longer facing reality and we're basically sticking our head in the sand. There are two characteristics that are in common. One, in terms of defense mechanisms, one is either denial or completely distorting reality, and the other is operating on that unconscious level, again, where we don't know why we're acting in a way or why we're being defensive about something, but that behavior that defense mechanism just kind of automatically pops up and we don't even know where it came from. I'll cover more of this in a separate video. So little hands, this is a kind of a case example just to share with you guys a little bit more about some of Freud's approach to different cases and theories. So Hans worked with this little boy. He was a 5-year-old named Little Hans who was brought to Freud by his father. And so the father was looking for help with little Hans because Hans had a fear of horses. Now, he was 5, his family lived and worked near a busy coach inn. So, coach inns in the old days, horses were pulling buggies in and out as people were trying to get to their destination. Think of it as a hotel. And so what happened was that he was very afraid of horses. Apparently, he had watched a horse pulling a lot of people or people in a wagon or some type of coach. He'd watched the horse collapse and die in the street in front of him. So he was very afraid of them. And so Freud decided to try and treat this little boy. And you can probably guess that his explanation for this little boy's fear wasn't due to witnessing the traumatic death of a horse. According to Freud, Hans was particularly scared of horses that had black muzzles, and he saw this as an association with his father's mustache. And he didn't like horses that had blinders on, apparently, according to Freud, because this was an association with Hans of his father wearing glasses. Eventually, Freud diagnosed this little boy's fear of horses as an extension of his Oedipus complex. And so the horse, according to Freud, represented his father, largely because of the mustache and the glasses comparison, glasses and the horses wearing blinders, along with the tendency of male horses to be well endowed. I'm curious to imagine exactly what type of research Freud was doing that resulted in him somehow coming to this conclusion. I'm not sure how they researched this or what they did. Did they take Hans out to a male horse and then a female horse and say, well, he's less afraid of female horses? I'm not sure what this looked like. Anyways, little Hans, according to Freud, was in the middle of also developing an intense and sexual love for his mother at 5 years old, and saw his father as a rival for her love and attention. His father was, of course, considerably bigger and stronger than he was, leading to this development of a fear of his father, and by extension, therefore, of horses, as horses represented his father and vice versa. Because much of therapy at the time was done with Hans' father acting as an intermediary between the two, Freud and Hans, Freud determined that his fear of horses wasn't going to go away anytime soon. And so his therapy was basically dependent on this other person who Hans was afraid of. So he eventually sat down and just talked to the little boy, I guess without his father present. And he reported that basically everything within that counseling session or therapy session uh, further enforced what he believed in terms of his theories and what he had already determined about the Oedipus complex with little Hans. I just want to poke a hole or two in that. It really seems like Freud already had his conclusions made up before he talked to little Hans. And so even if Hans had said, no, that's not the case, I'm afraid of horses because they're way bigger than I am, it kind of seems like Freud would have basically said, like, no, that's not what's really going on here. I'm also really curious how this conversation went, given that Hans was a 5-year-old boy. And most 5-year-olds I know aren't super, super articulate in terms of, like, this is what's going on. Big horses scare me because of XYZ. And so I'm wondering how much talking little Hans actually did in this counseling session. So this is just a case that I wanted to share with you guys of what Freud's therapy cases looked like. Don't worry about little Hans. It apparently turns out that he grew up, and Freud checked in on him when he was 19 or 20 years old, and apparently he had completely forgotten the whole thing and completely forgotten that he'd even seen Freud. So apparently he went on to live a very normal life. Freud's psychosexual stages. So these are the phases of development that Freud believes that we go through as we progress and develop throughout different stages of our life. This is another topic that I will record in a separate video. So what are the goals of therapy within psychoanalytic work? Well, one is to increase adaptive functioning. So this is reducing symptoms that clients are experiencing and resolving whatever conflict that they're experiencing as well. We've already talked a lot about making the unconscious conscious and bringing whatever those drives and desires and wants are into a client's awareness. We also would want to, if we're using this therapy orientation, we would want to strengthen the ego so that behavior is based more in reality and less on instinctual cravings, basically less on that id side of things. And we would also want to increase self-understanding, self-awareness, and it's assumed that making these changes, increasing that self-awareness, will then lead to a decrease in those negative symptoms and those unhelpful behaviors that we might be experiencing, driven possibly by the id. So our role as therapists, there's several things that we're going to want to be paying attention to and doing. And there's several factors that this therapy has in terms of the therapist function and role that you won't see in other therapy approaches as we go through the semester. One of those is a blank screen. And so therapists who, again, depending on how strongly psychoanalytic you are, therapists from this approach tend to view therapy and present in therapy as a blank screen. So I know therapists who won't have pictures of their family in their office, won't have, their office is basically very bare to kind of continue to project within the environment this very blank approach. They maybe won't, hang pictures on the wall because they want to have that blank approach. And they'll kind of leave themselves out of therapy to present in this very blank, non-judgmental stance. Try to really let the client bring into therapy whatever it is that they have going on. Empathy, of course, we want to be empathetic, and you're going to see that consistently across all approaches. Being open-minded. The therapeutic alliance is something that is also going to be hugely important across pretty much every therapy orientation that we'll cover this semester. So the therapeutic alliance or the therapeutic relationship, that's the client's tendency to view the therapist in terms that are shaped in terms of his or her experiences. And so in terms of therapeutic alliance in general, we want to have a strong relationship with our clients so that we can work together to help move them in whatever direction they want to go. In terms of psychoanalytic specifically, this moves more in towards kind of that transference side of things, where psychoanalysts view that or believe that the client might be projecting onto them whatever their experiences are, and will see the therapist as a caregiver, or maybe kind of match them as what, that's not how I would want to say it. Like basically, okay, if if I've lost my mom, for example, this therapist is now replacing my mom. She's now my caregiver. This therapist is now a significant figure. I would see her as a significant figure. And so that's how psychoanalysts view this relationship, and how that relationship plays out, or how the client presents, is very much say a daughter or someone who needs to be cared for, given that the belief is that the client is transferring those past experiences onto us as the therapist. Active listening, of course, this is hugely important, and it is a useful skill. It can be very easy in therapy, or not easy, but it's something that I think we all struggle with, in terms of, you're talking to someone and suddenly you realize that you're thinking about what's for lunch later, or what are things that you need to do, what do you need to buy at the store on the way home. And so making sure that we're staying present and staying in the room with our client and being present for them is definitely a skill that will be worth practicing as you become a therapist and move on to working with clients. We want to, and I would say that this shows up across therapy orientations, is we want to build the client's ability to solve their own problems, become independent, and eventually move on with their life and not stay in therapy with us forever and ever and ever. And then countertransference, part of our role as the therapist is to manage our countertransference so that it doesn't negatively impact therapy. And countertransference is basically if we experience some kind of emotional reaction to the client. For example, if he or she says or does something that would cause us to be irritated or annoyed by them, we would need to manage that so that it doesn't negatively impact therapy. And I'll talk about this a little bit more in the next slide. So therapeutic techniques, here are some of the techniques that we use. Maintaining the analytic framework. I had a supervisor in grad school who felt very strongly about this, and this is maintaining the framework basically means setting the structure within therapy so that clients always know what to expect. They always know what's going to happen. They always know what things are going to look like. So that's things like starting and ending therapy on time, that type of thing. Free association. For example, a therapist might say something like, I'm going to say a word and I want you to spend a few minutes saying whatever comes to mind. So for example, if the client is feeling angry at work, they might ask something like, where else is this showing up? Or the therapist might say something like home, and then the client will say structure, responsibility, stress, frustration, feeling overwhelmed. And then from there, from that free association, interpretation will then happen to explore, all right, well, you said these things, and does that tie to this, or does that tie to your work stress that you just talked about, or how are these two things tying together, or what's going on here? In terms of interpretation, timing here is everything, to make sure that your interpretation lands correctly, to make sure that it resonates with the client, to make sure that it's coming from a place where it will be helpful from the client and maybe not something that's going to detract from therapy or that maybe doesn't sit well with the client or that's maybe confusing. Dream analysis, so this is interpreting dreams and uncovering meanings. Again, what's occurring in the unconscious, what are those wants and desires that are occurring within dreams, and bringing awareness to those. Resistance, this is anything that works against progress in therapy. So for example, I've worked with clients who identify their goals as, I want to work on my depression or my anxiety, etc. And they won't say anything about the fact that their marriage is falling apart. And so that could be potentially a resistance in therapy of, hey, is it possible, if we explore this, that the fact that your marriage is falling apart is contributing to your anxiety and depression? And it's a resistance because if they're very much like, nope, I don't want to talk about that. I don't want to, everything is fine in my marriage. We're not discussing that. That could be a resistance, and that could possibly prevent therapy from moving forward or being as beneficial as it otherwise could be, as they're potentially repressing stuff within the relationship. Transference. We've kind of already talked about transference, but again, this is a client putting their experiences onto the therapist. An example of this is in grad school, one of my professors was pregnant and she was about to start her maternity leave. And she was seeing a client, and the client basically told her, like, once she went on maternity leave, the client was going to terminate therapy. And the therapist took that as, okay, well, this client is experiencing something internally. We didn't talk about the case a ton, but something internally, and viewing me as a caregiver for her or as a mother for her, and we discussed at that point, like, what was going on. Was it possibly that the client had, had a baby sister be born, and her mother, maybe she felt abandoned by the fact that her mother then put more energy into the new baby, and she didn't want to re-experience that with her client, with her therapist, as she, felt that or believed that her mom was her client. Her therapist was filling the role of her mom. Man, I said that very confusingly. Anyways, hopefully you get the idea there. So it was a cool case that we discussed, and hopefully it's an example of how transference can show up in real life with a client, in terms of, for that client, she said, for whatever reason, we didn't discuss the case in depth. For whatever reason, she decided to terminate treatment rather than re-experience whatever that hurtful, whatever it was that within that relationship with her therapist. Anyways, moving on. Working through is identifying defense mechanisms or defense structures and how they have served and been beneficial to the client in the past. How they've maybe helped resolve old patterns, but also identifying how to help the client make new choices and develop relationships that are more corrective in nature, and basically using ourself as a tool within this to help the client make more corrective action in terms of our relationship with the client, so that then will hopefully kind of move out into other relationships, kind of like a ripple effect, move out into other relationships in their life. And then lastly, I think we've already talked about countertransference. One way that therapists within this approach will handle countertransference is self-disclosing it and bringing it into the therapy space. So for example, if a client says something, the therapist would then immediately address it and say, like, I'm having a reaction of being irritated towards you as the client, and I'm experiencing you as being demanding, and I'm wondering if you've received that type of feedback from others in the past. That's one way to handle it. That can be, depending on, I think, how you approach that, can be very conflictual, especially if it's something that could maybe be kind of triggering for the client, or if it's something that they don't really want to hear or they don't want to get feedback about, it potentially could negatively impact the therapeutic alliance. So I think it's something that would have to be handled very gently in terms of how it's brought up, and of course depending on what the situation is or what the therapist says, it could also be very helpful and very useful for the client of, like, oh, I didn't, right, again, bringing that unconscious to the conscious, like, oh, I didn't realize that that's maybe how other people are experiencing me or perceiving me. That's really interesting to know. Let me think about that, or let's explore that. So for example, continuing that conversation with, have other people experienced you as demanding, or have you received that feedback from other people at work or in your school life or in your home life? One thing that is important to pay attention to, and that can be very helpful as a therapist, and this comes up, I think, kind of throughout the semester, is also getting your own therapy or your own consultation and making sure that you're in supervision to work through your own countertransference within therapy so that it's not negatively impacting the therapeutic relationship. Group therapy can be very beneficial, and this is basically kind of similar to what we just talked about in countertransference. It's recreating life situations in order to help the client identify how they are maybe negatively acting in relationships, and how that behavior might then be negatively or be harmful to a relationship. So, for example, if one group client member, say, I'll call her Anna, if Anna snaps at John, that's something that the therapist might then bring to everyone's attention, or bring to the group's attention, and say, hey, Anna, I just noticed that you snapped at John. This is probably not what this sounds like, but this is, I just noticed that you snapped at John. What's going on there? Have you snapped at other people in your life? Well, let's explore this a little bit more. So it's recreating not only current life situations, but also early life situations, maybe something from childhood, that type of thing. So the group basically becomes a microcosm of the member's everyday life as you're recreating those situations or exploring how the member is acting. Transference, countertransference, we already talked about that. Within a group, part of what can occur is that the members might compete for the therapist's attention. If there's, say, 8 of you in a group, there might be this, again, because of the idea that the client is basically has this relationship with the therapist that's of a caregiver, there might be almost this kind of sibling rivalry, if you will, to want to get the therapist's attention. Projections onto the leader and members are clues to unresolved intrapsychic conflicts that can be identified, that can be explored, and that can be worked through. So group therapy can be really beneficial because, of course, there's more than just one of you, whereas in individual therapy, it's just you and the client. But in this setting, there's other people who can also add their voice and can also add their experience or their perception of, like, hey, Anna, here is what I felt, or here's what I thought when you snapped at me that way. Or, from Joe, hey, Anna, or Bill, hey, Anna, this is my experience of watching you snap at Joe, and this is how I thought that interaction went. So you get way more feedback, which can be really helpful, again, to add that insight of someone's behavior and how others might be perceiving that behavior. You do want to be very careful, though, because pushing the client too rapidly or pushing them too far out of their comfort zone, basically putting too much strain on the therapeutic relationship, can result in interruptions to therapy, can result in the therapeutic process in general becoming ineffective, and can result in possibly clients dropping out of therapy and basically saying, hey, this is too much, or this isn't what I thought I signed up for. So being very careful about how conflicts are managed, especially within a group therapy session, is hugely important. So this is the first therapy orientation that we're discussing. So pay attention to and read Stan and Gwen's cases at the end of the textbook chapter, and look at how those cases are presented, how the therapist within those cases are handling whatever is being said within the therapy session. I think it will be a really good example to see some vignettes for you guys. Historical psychoanalytic theory has several criticisms, one being that it doesn't attend to and pay attention to culture and socioeconomic groups. Of course, in the 1800s, 1900s, when Freud was alive and practicing in his theory, I don't think they were hugely considering culture and socioeconomic groups. So, of course, those things are not factors that he hugely considered. Deterministic, it's a focus that it doesn't really emphasize current maladaptive behaviors. So, again, right, paying attention to the orientation, Freud was heavily focused on early childhood. And so sometimes that can be dismissive of what's currently going on, and what's currently going on in environments as well. So, for example, what's going on in the client's work life, what's going on in their school life, in their home life, in their church life, in their interpersonal friend life. So it doesn't necessarily pay attention to all of those different environmental factors, life stressors, what's going on in general. And that can be a huge limitation if you're, very strongly psychoanalytic, following very closely Freud's original theory approach. The other factor is that in terms of original theory and approach, Freud was psychoanalysis in general takes usually 3 to 5 meetings a week and requires the amount of time, usually like 3 to 7 years, which most people in today's day and age, one, cannot afford that because 3 to 5 sessions a week can be very expensive. So one, it's not affordable, and two, just with how fast paced today is, it's really not practical in terms of the time that's required to fulfill that. So research. This research was conducted by Probst and colleagues in 2017. And what they did was they looked at alexithymia, which is a broad term to describe problems with feeling emotions. In fact, this Greek term is used in Freudian psychodynamic theories, loosely translates to no words for emotions. Just an interesting fact there. So this study used brief psychodynamic interpersonal therapy for patients with multisomatoform disorder and investigated whether alexithymia moderates the associations between the therapeutic alliance and the outcome of therapy for depressive symptoms. If you don't know, multisomatoform disorder is 3 or more currently bothersome physical symptoms, and somatoform is a tendency to experience and communicate psychological distress as bodily symptoms. So, for example, you might be experiencing psychological distress, but how that comes out is maybe a lot of physical tension in your shoulders, or headaches, or some type of other body ache that's unexplained in a medical diagnosis. So 83 patients completed the study, and what they did was they completed several different assessments as part of this. So they completed a health assessment, they completed the Toronto Alexithymia Scale, which is a measure to look at alexithymia. They looked at Therapeutic Alliance, which helps identifying how strong the therapeutic alliance is, and that's called the Helping Alliance Questionnaire. And they looked at a screener for depression, which is called the Patient Health Questionnaire, or PHQ-9. So they looked at a whole bunch of data. And inclusion-exclusion criteria, basically, they included individuals who were experiencing multisomatoform disorder and excluded individuals who were not, because this is a specific category or topic that they wanted to look at. And in terms of limitations, there were several for this study. They only assessed the therapeutic alliance at the end of the intervention, which is interesting, and that's something to pay attention to for future research. It would be really interesting to know if they did the therapeutic alliance at the beginning of the research, did the intervention, and then got the therapeutic alliance scale after the intervention to see did the therapeutic alliance change over the course of treatment or not. Something to do for future research. Another limitation, which you will see consistently in research, is that we use assessments that are often self-report, so the client just fills out whatever the assessment is, and oftentimes that can be biased, especially if the client knows or the participant knows what you're looking for in the research. That can result in people maybe, responding in a way that's favorable towards the research, if they know what the researcher is looking for. And so this is where like blind or double-blind studies come in to try and prevent the participants from knowing specifically what the research is looking for, to try and prevent those biases from occurring, so that your results are as true and as accurate to what you're actually looking for as possible. So yes, self-ratings, one limitation. You'll see that consistently. Future research. So one option we already talked about is doing a pre and post for the therapeutic alliance and seeing if there were any changes over the course of treatment. Another future research option is using an observer-based assessment. which might be helpful instead of using those self-assessments. Again, just to be more objective with the testing results and with the results in general, as opposed to maybe letting some biases seep in. In terms of the results, so for patients scoring above the threshold of 61% or 61 points for the alexithymia assessment, those individuals resulted a stronger therapeutic alliance, which was significantly beneficial. So that's something that's interesting. And for a stronger therapist alliance, alexithymia moderated the effect exerted on the outcome of treatment. So the results also showed that it's really important to pay attention to the therapeutic alliance. No surprise there. That's one of those aspects that hugely impacts treatment outcomes. What's the impact for me as a therapist? Well, if I run around assuming that everything, if I run around just making assumptions, one, I might miss something. And two, sometimes we don't pay attention to physical concerns. So for example, sometimes I've fallen into this trap or made this mistake where, I kind of assume or I think, like, well, this person is saying that they're experiencing a headache. That's for their PCM, their primary care manager, or their doctor to manage. That's, a physical illness that's going on. And sometimes I tend to forget, all right, well, there is this mind-body connection. So let's explore if that's something that is tied to the psychological side of things, not the physical side of things. So if we make assumptions, we might miss something. So slowing down, checking in, identifying if there's something deeper, something else going on, and also always paying attention to that therapeutic alliance. So here's one of your discussion questions for this week. There are several different concepts within psychoanalysis that we have not discussed for this lecture. So identify one or two of those in your textbook and then write about it, give some examples in Canvas for the discussion post. And then your other discussion question will be in one of the other lecture sections that I post for this week. And here are my references. You guys have a good week.